Today we discuss about sections of the spinal cord. Sections of the spinal cord. The first of these sections is complete transection of the spinal cord. Complete transection of the spinal cord. What is the cause of complete transection? Fracture dislocation. Fracture dislocation of the vertebral column due to stab wound, bullet wound, and separating tumor. So cause of this complete transection is fracture dislocation of the vertebral column due to stab wound, bullet wound, and separating tumor. Immediately after the complete transection of spinal cord, there is stage of spinal shock, or stage of flaccidity, or spinal shock. What happens that there is flaccid paralysis below the complete transection. Flaccid paralysis, loss of voluntary movements along with loss of the muscle tone. So loss of voluntary movement along with the loss of muscle tone is flaccid paralysis. All superficial and deep reflexes are lost. All superficial and deep reflexes are lost. There is loss of all the sensations. Smooth muscle, tone disappears. Even the tone in the sphincters disappears. To start with, after transection of spinal cord, there will be incontinence of the urine or feces. So there will be incontinence of the urine and feces. Muscles lie in the position imposed by the gravity. So muscles of the body lie in the position imposed by the gravity. If transection is in the segments T1 to L2, if the complete transection is in the segments T1 to L2, there is loss of vasomotor tone, fall in the blood pressure. So after complete transection of spinal cord, the legs are cold, pale, and bed sores may appear. The stage of spinal shock, it remains for 2 to 3 weeks. So this stage of spinal shock remains for 2 to 3 weeks. What is the cause of spinal shock or stage of flaccidity? The cause is loss of tonic facilitatory effect. Of corticospinal, reticulospinal, and rubrospinal tracts. So the cause of spinal shock is loss of tonic facilitatory effect of the corticospinal, rubrospinal, and reticulospinal tract, and also the vestibulospinal tract. So these tracts are lost. So there is no facilitation on the spinal cord, and this results into spinal shock. After 2 to 3 weeks of spinal shock, the next stage is stage of reflex activity. Muscle tone begins to reappear. First in the smooth muscle, first in the smooth muscle, and also in the sphincters, and also in the sphincters muscle tone. This muscle tone begins to reappear in the smooth muscle first, and then in the sphincters. So, in the vesical sphincter, urinary sphincter muscle tone appears. Similarly, in the anal sphincter, muscle tone appears. So this leads to retention of urine and feces. It leads to retention of urine and feces. Vasomotor tone also begin to reappear. Vasomotor tone also begin to reappear because the neurons in the spinal cord, have learned to function in the absence of facilitatory impulses from higher centers. So neurons in the spinal cord have learned to function without the facilitatory impulses from higher centers. So vasomotor tone begins to appear. And next, tone in the skeletal muscle begins to appear. Tone in the skeletal muscle begins to appear. But this tone is not as much as normal. This tone is not as much as normal because of the weak myotatic reflex. Because of the weak myotatic reflex, this muscle tone which begins to appear is not as much as the normal. Skeletal muscle tone first appears in the flexors. It first appears in the flexors of the body. Flexors of the body becomes less flabby, and legs remain semi-flexed. So legs remain in flexed position. And this is called paraplegia inflection. So next are in semi-flexed position or flexed position, and this is called the paraplegia inflection. So keep in mind this feature of the complete spinal cord transection, that is the paraplegia inflection, is important to keep in mind. Spontaneous contractions in the different parts of the body begins, and these spontaneous contractions are in the flexors. These begin in the flexors. Muscle shows contraction during reflex activity. Muscles show flexion during reflex activity, but not for the voluntary movement. Not for the voluntary movement. Flexor reflex can be elicited. Flexor reflex can be elicited. Flexor reflex can be elicited, which is accompanied by the crossed extensor reflex. Accompanied by the crossed extensor reflex. Erection is not possible at this stage. So penile erection is not possible at this stage. Then what happens? That mass reflex can be elicited. Mass reflex can be elicited, And what is this mass reflex? Now when skin on any part of the legs or anterior abdominal wall is scratched, when skin on any part of the leg or anterior abdominal wall is scratched, it results into three responses. So three responses when skin on any part of the leg or abdominal wall is scratched. Contraction of flexors in the leg, contraction of flexors in the leg. Number two is evacuation of the urinary bladder, even if it contains small quantity of urine. So evacuation of urinary bladder, even it contains small quantity of urine. And this is partly due to increased intravesical pressure due to contraction of the muscles of the abdominal wall. So urinary bladder is evacuated even if it contains small quantity of urine because of the contraction of the muscles of abdominal wall, which will increase the intravesical pressure. And the third effect of this mass reflex is there is profuse sweating. There is profuse sweating. There is profuse sweating. So after the start of reflex activity, erection can occur in males. In males, erection can occur whenever skin over the glans penis or skin over the inner side of the thigh is scratched. The result will be erection in males. Now, within 3 to 4 weeks or so, recovery occurs. Now, after the recovery, below the level of transection, there are features of the upper motor neuron region. So after the recovery, below the level of transection of spinal cord, there are features of upper motor neuron region with brisk ankle jerk, knee jerk, Babinski sign is positive, there will be rigidity in the muscles. So all the features of the upper motor neuron regions, these are present below the level of transection. Sensations do not recover, keep in mind. Sensations do not recover. So no recovery regarding the sensations. Now regarding the defecation and micturition, there is reflex micturition and there is reflex defecation. So reflex micturition and defecation can occur. And the patient learns how to elicit reflex for micturition, how to elicit reflex for defecation. Patient may scratch skin on the inner side of the thigh, peri-inner region to elicit the reflex for micturition or reflex for defecation. Right? So this was about the features during the stage of return of reflex activity or stage of reflex activity. Now in this condition, if patient is given good nursing care, proper management, patient may live for years. So patient may live for years if he is given good nursing care, good management, patient can live for years. But stage of failure of reflex activity may occur. Stage of failure of reflex activity may occur if there is generalized infection or toxemia. So if there is generalized infection or toxemia, then there is failure of the stage of reflex activity. What happens this failure of reflex activity stage? Reflexes become difficult to be elicited. Reflexes become difficult to be elicited. Flexor reflex can't be elicited. Response in the reflexes decreases. Response in the reflexes decreases. Muscle tone decreases. Bed sores appear. Bed sores appear. And patient become worse and worse. It become worse and worse. So this stage of failure of reflex activity occurs when there is general infection or toxemia. Difficult to elicit reflexes, flexor reflex can't be elicited, maybe bed sores appear, and patient become worse and worse. So this was about the complete transection of the spinal cord. Now we come to the incomplete transection of the spinal cord. Incomplete transection of the spinal cord. In incomplete transection spinal cord is severely damaged, but not completely transected. Spinal cord is severely damaged, but not completely transection. Now in this incomplete transection spinal cord, same cause, fracture dislocation of the vertebral column due to bullet wound, stab wound, or spreading tumor. Now in the incomplete transection, first will be the stage of spinal shock of flaccidity, and then comes the stage of reflex activity. Now in the stage of reflex activity, when muscle tone appears in the skeletal muscle, first it appears in extensors. And the legs are extended at the hip and knee. And this is called paraplegia in extension. Paraplegia in extension is a feature of incomplete transection of the spinal cord. So paraplegia in extension is a feature of incomplete transection of the spinal cord. So why is there paraplegia in extension? Why muscle tone first appears in the extensors? The reason is that in incomplete spinal cord transection, reticulospinal and vestibulospinal tracts escape injury. So reticulospinal and vestibulospinal tracts escape injury, and these two tracts are facilitatory for the extensors of the body. So in the incomplete transection, the reticulospinal and vestibulospinal tracts escape injury, and these two tracts are facilitatory for the extensors of the body. So that is why muscle tone first appears in the extensors of the body, and there is paraplegia in extension in the patients having incomplete transection of the spinal cord. In these patients, there is extensor thrust reflex, extensor, thrust reflex, extensor, thrust reflex. What is that extensor thrust reflex? Patient is lying on the bed on his back. Patient is lying on the bed on his back. His one leg is flexed. One leg is flexed, and his foot of the flexed leg is lying on the bed. So one leg is flexed and his foot is lying on the bed. The examiner with the palm of the hand, exerts upward pressure on the sole of the foot. The examiner with the palm of his hand exerts upward pressure on the sole of the foot. Right? So examiner with the palm of his hand exerts upward pressure on the sole of his foot. This results into contraction of quadriceps. It results into contraction of quadriceps, and posterior calf muscles. So contraction of the quadriceps and posterior calf muscles, and leg becomes straight. Leg is straightened. So the examiner with the palm of his hand exerts upward pressure on the sole of his foot. There is contraction of the quadriceps and posterior calf muscles so that the leg is straightened out, leg becomes straight. This is the extensor thrust reflex. The other test is Philipson reflex. Philipson reflex, and that is patient is lying on his back, and one leg is flexed. After some time, the other leg becomes extended. One leg is flexed, other leg becomes extended. After some time, the flexed leg becomes extended and the extended leg becomes flexed. After some time, the flexed leg becomes extended and the extended leg becomes flexed. So this is stepping movement. So it means patient with incomplete transection of spinal cord can perform stepping movements. So stepping movement can be performed, but walking is not possible. Stepping movement can be performed. Right? This is called the Philipson reflex. Now after recovery, in this patient, there are features of lower motor neuron lesion at the level of incomplete transection. So features of lower motor neuron lesion at the level of incomplete transection. And below the level of transection, there are features of upper motor neuron lesion. So below the level of incomplete transection, there are features of upper motor neuron lesion, that is rigidity, Babinski sign positive, brisk tendon jerks. So all these features of upper motor neuron lesion are present below the level of incomplete transection. At the level of transection, and below. There is sensory loss, and this sensory loss is 2 to 3 segments below the level of incomplete transection because of the crossing over of spinothalamic fibers from one side to the other. So loss of sensations is seen below the level of incomplete transection. That is about, say, 3 to 4 segments below the transection. It is due to the crossing over of spinothalamic fibers from one side to the other. So this was about the, in addition, you say that there will be problems in the control of micturition and defecation. So there are problems in the control of micturition and defecation. So this was about the features of incomplete transection of the spinal cord. Now we come to the hemisection of the spinal cord. Spinal cord, which is also called brown sequard syndrome. Which is called brown sequard syndrome. Now in the spinal cord hemisection, of course, half of the spinal cord is sectioned. Half of the spinal cord is sectioned. What is the cause? Same cause. Same cause as that of the complete and incomplete transection, that is fracture dislocation. Fracture dislocation of the vertebral column due to bullet wound, stab wound, and spreading tumor. So fracture dislocation of the vertebral column due to bullet wound, stab wound, and spreading tumor. So after the spinal cord hemisection, the stage of spinal shock, and then comes the stage of reflex activity, and finally there is recovery after the hemisection of the spinal cord. Now, what are the features of the hemisection spinal cord? So features can be discussed below the level of hemisection, at the level of the hemisection, and then above the level of the hemisection. So below the level of hemisection, at the level, and then above the level of the hemisection. So first about the features below the level of hemisection. Features below the level of hemisection. There is upper motor neuron type of paralysis ipsilaterally below the level of hemisection. So ipsilaterally, I mean on the same side of hemisection, ipsilaterally there is upper motor neuron type of paralysis below the level of hemisection, and that is ipsilateral. On the contralateral side, no motor loss. On the contralateral side, no motor loss below the level of hemisection. So keep in mind, ipsilaterally there are features of upper motor neuron lesion below the level of hemisection. Ipsilateral. Now regarding the sensory loss, below the level of hemisection, there is ipsilateral loss of sensations carried by dorsal column medial lemniscal system. So ipsilateral loss of sensations carried by the dorsal column medial lemniscal system. And what are these sensations? Fine touch, tactile discrimination, vibration, proprioception. So these are lost ipsilaterally below the level of hemisection. So sensations carried by dorsal column, medial lemniscus system are lost below the level of hemisection ipsilaterally. On the contralateral side, there is loss of pain, temperature, pressure, crude touch on the contralateral side. So sensory loss on the contralateral side below the level of hemisection is loss of the sensations carried by spinothalamic tract. So loss of sensation carried by the spinothalamic tract that occurs contralaterally on the opposite side below the level of hemisection. So below the hemisection, ipsilaterally, loss of sensations carried by dorsal column, medial lemniscus system, and contralaterally, loss of sensation carried by the spinothalamic tract. So this was about the motor loss and sensory loss below the level of hemisection. Now about at the level of hemisection, there are features of lower motor neuron type of paralysis ipsilaterally at the level of hemisection due to damage to the alpha motor neurons or ventral root of the spinal nerve. So features of lower motor neuron type of paralysis at the level of hemisection ipsilaterally due to damage to the